Welcome, everyone, to the March Alumni Lunch and Learn for the L. Douglas Wilder School of Government and Public Affairs at Virginia Commonwealth University. My name is James Wazalewski, and I am the Director of Development for the Wilder School. And thank you so much for joining us and taking time out of your day to be part of this conversation. Our session today will feature our guest speaker, Dr. Norman Oliver, as well as our moderator, Dr. James Burke, for the presentation and discussion about Virginia's COVID-19 vaccine planning and administration response. As a reminder, we are recording this session as well as a question and answer Q&A session. This includes comments in the chat. For those of you who wish to enable and closed captioning for the live session, please click on the CC Live transcript icon in your Zoom meeting controls at the bottom navigation bar. If you cannot see this button, click on the More icon. From the pop-up box, click the Enable Auto Transcription button. We are pleased to have each of you here for our session as we continue efforts to engage and involve our alumni and our community. At this time, I would like to introduce Dr. Susan Gooden, Dean and Professor at the L. Douglas Wilder School of Government and Public Affairs. Dean Gooden.
Thank you so much, James, and welcome everyone to our March Alumni Lunch and Learn. We're very excited that you've joined us this afternoon, and I know that we're all going to learn a lot from Dr. Oliver and his presentation today. I do want to say, I'm proud to serve as Dean of the nationally ranked L. Douglas Wilder School of Government and Public Affairs. And I think today's presentation highlights some of the expertise that we have in the school relative to social equity and racial justice, and these being areas of emphasis that are part of the fabric of the Wilder School. If we think about our namesake, Governor Wilder, who's been involved in these issues in public service since 1969 and continues to be a very strong and respected voice, not just in Virginia, but throughout the nation. And within the Wilder School, of course, we have the Minority Political Leadership Institute. We have our Research Institute on Social Equity. And we have a number of faculty members who are doing research in this area, particularly related to the pandemic, looking at the plight of minority-owned businesses, individuals who are potentially facing eviction, and looking at vaccine equity throughout the state. So we are very proud to be for all of the work that our faculty members are doing and to try to support this important and critical work. Before I turn it over to Dr. Burke, Jim Burke, to introduce Dr. Oliver, I do want to mention that we will have our EVGA, our Excellence in Virginia Government Awards Luncheon. That is going to be on April the 15th. At the close of this session, James Wazalewski will come back and talk a little bit more about that. But for those of you who are familiar with the event, you know that this is a signature event of the Wilder School. Typically, we gather in the Richmond Marriott and recognize individuals. We won't be able to do that this year, but we have a very exciting virtual event planned. And I think it's a great way to showcase all of the excellence that is happening in government throughout many areas, public-private partnerships, excellence, Lifetime Achievement Award, all of these things which are critically important. When we think about Virginia being part of the best managed state, and of course we know that is a direct testimony of the many individuals who are working hard in positions day in and day out. So at this point, I would like to turn it over to my dear colleague, Jim Burke. Jim is director of the Performance Management Group, and many of you might know the work of PMG and Jim's outstanding leadership in our Virginia Executive Institute, VEI, CMI. He's done a lot of strategic planning and coaching, organizational development for organizations throughout the state and in local government. So I am delighted that Jim is moderating this session. I also want to extend a warm welcome to Dr. Oliver and to express my appreciation as a citizen of the Commonwealth of Virginia for all the hard work that you've been doing throughout this pandemic. We know that it's not easy, that difficult decisions have had to be made. But one thing that I think is really clear is that Dr. Oliver's commitment to racial equity and vulnerable populations far predated and preceded the pandemic and the work that he's done today. And it's great to have that experience at the helm of state government. So, Jim.
Thank you so much, Dean Gooden. Much appreciated. And I really do we value your leadership so much. And it's been a pleasure to work with Dr. Oliver. I think, Dr. Oliver, can you just let us know if you're having technical problems? I think there might be a little glitch in there. I think we'll at least have audio. So can you hear us, Dr. Oliver?
Oh, yes, I can.
Okay, great.
The
Okay.
host, okay.
Yeah, it looks like there's some technical issues over there, huh?
The host has to
there's
start
that
my
face.
video.
There's that face. Great. It is such a pleasure to be with you today and to be with our wonderful audience. Dr. Oliver has a wonderful career. And as you know, of course, is Commissioner of VDH since spring of 2018. And before that, Deputy Commissioner for Population Health. And then 17 years at UVA, where he held a Walter M. Seward Professorship and was Chair of Faculty Family Medicine. I brought a real focus on patient-centered care to UVA. But we will be talking about his earlier career, which fascinates all of us, how somebody decided to go to medical school at 40 at Case Western and then got about as far away as you can from Ohio to go to Alaska. My dear colleague Linda Pierce from Ohio would certainly support you and your decision in that to work in a rural fishing village. But as Dean Gooden mentioned, your interest in your area for anybody who's disenfranchised or cut out of the main health of America was included. And so we want to spend some time on that when we talk about the vaccine and health issues, and certainly want to look at several different other issues. We'll just kind of work off each other. We're going to have Dr. Oliver just open up with some starting comments, and then he and I will just engage in a conversation. And around 12:35, we'll go ahead and open the floor up for other questions. I will be selfish and take some time that we can, because talking with Dr. Oliver is a sheer joy. I wish we could be having this conversation in Charlottesville over a glass of wine, and all 100+ people could be joining us too. So Dr. Oliver, with that, I would like to open the floor to you for your opening comments, and then we'll go with Q&A and just flow from there.
Well, thank you very much. I appreciate those kind remarks as an opening. I'm at the Emergency Operations Center out in Midlothian. This is the center through which our Virginia Emergency Support Team operates and carries out its work in disasters for hurricanes, tornadoes, other disasters, and it's also where we've stood up the VEST to carry out the vaccination campaign. And earlier last year, we set up the VEST to launch and maintain all of the testing that we did around COVID-19. So anyway, I'm here with lots of other people, so I have my mask with me. What I'd like to do is just very briefly say a couple words about the pandemic and where it stands and the vaccination campaign and what we're doing around that. And then we can just have a conversation around those sorts of issues. And then you mentioned a couple other more personal things you wanted to talk about, and we can certainly do that. And I look forward to getting the questions from all the people who've joined the webinar. The most important thing I want to say about the pandemic is that people need to realize that it's still here. We've been dealing with it for more than a year. I know that many of us are feeling a lot of fatigue, wishing that it was over, but the virus is still out there and with pretty widespread communication and widespread infection in the community. We currently have about 16. Well, no, it's dropped a little bit. It's about 15 cases per 100,000. We need to be well below 10 cases per 100,000 in order to not be seeing widespread community spread of the virus. We're averaging somewhere around 1,300 new cases every day. You will remember that back in April and May of last year, that was when we were completely all freaking out practically, right, about with that number of cases. And we're still there. We've sort of plateaued at that level. In addition to the new cases that we're seeing every day, we also are seeing the advent of variants to that virus. Viruses mutate all the time. And there's probably hundreds of variants, but the ones that are concerning right now are the so-called UK variant, which is that B1117, which we know is more transmissible and more infectious, so to speak, so that it can spread more quickly. We, last time I looked, we had about 20 cases of that we knew of, but viruses are sort of like cockroaches. If you get 20, if you see 20 of them, there's a million of them behind elsewhere, right? So we suspect that it's actually pretty widespread in the Commonwealth, and various models would indicate that the UK variant could become the dominant variant in Virginia. We also have seen some cases of this so-called South African variant, B1351. So we're in a race against the variants. These two variants, fortunately, although they're more transmissible, do not cause more serious illness. I say we're in a race, however, because the longer that the virus has a chance to spread and mutate, you run the risk of it having a variation that is more deadly or causes more serious illness. So we're in a race to vaccinate people before that happens, get everyone vaccinated so that there's nowhere for the virus to live, and we'll then put an end to the pandemic. And to that end, we've have a new tool in our toolbox, which is the 3 vaccines. The Pfizer, Moderna, and now the Johnson & Johnson vaccines, which are all safe and effective means of protecting people from getting COVID, serious illness, hospitalization, and death from this virus. We now have the Pfizer and Moderna vaccines, came out first in December and January. We have been vaccinating as quickly as we can. Initially, the supply of the vaccine was pretty scarce, but that's been building up. We currently have about 2.8 million doses of the vaccine that have been administered. We've fully vaccinated now more than 1 million people in the Commonwealth. As I said, the supply of the vaccine has ramped up a lot. Initially, we were getting about 100,000 doses a week. This past week, we got in the Commonwealth about 515,000 doses. And as the supply increases, we're able, obviously, to get more people vaccinated. This week, we set up 3 community vaccination centers. These are large throughput centers that can do anywhere from the smaller ones do 1,000, the larger ones can do 3,000, and the largest ones can do 6,000 vaccinations a day. Over the next several weeks, we plan to set up about 13 of these community vaccination centers around the state, and that will mean lots of vaccination being done. To Dean Gooden's point about equity, equity has been at the center of everything we've been doing in this fight against COVID-19. I think Virginia has really led the way in this regard. Our emergency support team that I mentioned that operates out of this emergency operations center has, as an integral part of its general command, a health equity work group and a leadership team of that work group, which is led by the governor's chief officer for diversity and equity and inclusion, Dr. Janice Underwood. And through that means we've been able to ensure that every aspect of the work that we do is done through an equity lens. I'll say that as a result of that, I believe that we have done fairly well in terms of ensuring equitable response to the pandemic, but we have a long ways to go, and we're ramping that up as I speak. We have asked for and received, and thank you, Dr. Gooden, some really excellent work by Dr. Gooden and Dr. Douglas Glenn, looking at strategies for improving that equitable vaccination of our population. And using that strategy, we've employed a consulting and contracting team that is now deploying across the entire Commonwealth. We'll have boots on the ground in all 35 of our health districts to work with local health departments, leaders of local jurisdictions, community-based organizations, faith leaders, and others to do the work that will be necessary to reach out to Black and Brown people in the Commonwealth and draw them into the vaccination effort. I think increasing evidence has shown that there's a real myth about hesitancy in that community. The hesitancy there is actually much lower than it is in other areas. It's been more a problem of access to the vaccine, and we want to ensure that they get access to it, and that we are vaccinating this population the way they deserve to be, which is since they were the ones who were hardest hit by the pandemic in terms of incidence of disease and deaths, we want to ensure that they are prioritized in getting protection from it. So anyway, I don't want to eat up all our time talking about COVID-19. I'll leave it there. If there's any other issues or concerns around that you or others want to hear more about, I'm happy to answer questions. But just know that this Virginia Emergency Support Team, the VEST, is a whole of government approach that's dealing with this, and I think doing an outstanding job at it. And we're looking to get even better, particularly around the issue of equity.
Great. Thank you, Dr. Oliver. And your example and the example of our own Dr. Robert Wynn at Massey has just been wonderful in terms of, I think, shifting the perception to, and as you said, the numbers are much lower in the Black and Brown communities than originally thought, and more an issue of access as opposed to resistance. But we are seeing resistance 30 to 40%, depending upon the poll you look at over the past week within members of the GOP. And so how do we make interventions there too to help people understand that the vaccines are safe? If pharmaceutical industry was not exactly the most popular industry until the epidemic, or the pandemic rather, it was ranking slightly above maybe Congress, it's hard to say. But now most of us know at least 4 major pharmaceutical companies. But how do we break through, and how do we expand that too to other communities that may be resistant for other reasons? And this is a tricky problem.
Most hesitancy is probably not the best word for this. It caught on that there was vaccine hesitancy. I think it's a completely reasonable thing. Someone walks up to you with a needle full of some goop, and they say, "I want to shoot this into your body," and if you say, "Wait a minute, I want to think about it. I have a few questions," that's reasonable. And I think that's sort of the attitude we need to take. People have questions about it. We need to answer their questions. Is it safe? Give them the evidence. Talk to them about why it's safe. Explain how it got developed so quickly. That's one of the things that make people think that, how can it be so safe? Last time we developed the vaccine, it took us 4 years. Now this thing is done in just, less than a year. How did that happen? Well, being able to explain that technology around mRNA had been worked on for the last 15, 20 years. Actually, it was in Fauci's lab that they started that work back in the 90s under the Clinton administration. And there's other things that we need to answer about, does it alter your DNA? Will it prevent women from becoming pregnant? All these sorts of things. We have answers for all of these, and we need to give those answers to people. Is it effective? In talking about how effective these vaccines are. And then I think when you do that, you can convince a lot of people that it's worth doing. Although I would add that as much as people in the medical and public health science community talk about this, the most important voices for convincing people are trusted leaders, right? So I would say, I can talk for a long time on those sorts of things, but if someone's pastor or priest in their church or their imam or whoever their trusted faith leader is tells them that it's safe and effective, that has a lot more impact than almost anything I could say. So we have to get faith leaders and community-based leaders and other trusted leaders to do that. So I want to give a shout out to President Trump, who finally came out and told his supporters yesterday that they should get vaccinated. I think that will have far more impact on the Republicans who are, that, as you mentioned, about 40% of them saying they're not going to get vaccinated to come on board and get vaccinated. It's important because we need somewhere around 75-80% of the adult population to get vaccinated to stop this pandemic.
One of the things I've noticed about you in our discussions throughout this time has been your ability to come off of some very rough and difficult meetings and then stay calm, and you could even keep your sense of humor intact in some of those meetings that we had. And just from a leadership perspective, I'd love to know, is that just built into your DNA, as it were? Is that something you cultivate? Because we know you're a person of tremendous compassion, and looking at the death rates in Virginia weighs very heavily upon you. And so I'm just curious, from a leadership standpoint, how you maintain the calm in the midst of the storm.
Well, thank you for saying that. I think that part of its character. I mean, I think I have a what's the word I'm looking for? It's sort of my set point. I think of my set point as a thermometer analogy. There is one where I tend to stay that way. I do cultivate it. I have a daily practice of meditation, which helps me a lot in that regard. So those are ways in which I personally try to do that. I think that it's important to, as you say, have some compassion, to have some feelings about what's going on. Inside, I'm outraged over what's happening, right? You look at the inequities in this pandemic, and you look at the fact that African Americans are having incidences maybe twice that of whites of COVID-19. Same thing with respect to the levels of hospitalizations and death from it. With the Latinx community, it's even worse. They're younger, and the incidence is much, much higher. It's 3 times higher. Same thing in terms of serious illnesses. I mean, serious hospitalizations. We knew going into the pandemic that there are health inequities and that Black and brown people suffer more. And one of the things that is particularly galling is that knowing that, if we had to do it over again, I think we would have or should have organized ourselves differently with far more attention and priority put on protecting those communities, since we knew before. If you'd asked me just as an academic question, a year ago, if there's a pandemic, who's going to get hit the hardest? I would have said Black and brown people. Okay, knowing that, we should have organized around that. So we're playing catch up on stuff that we shouldn't be catching up on. Now, I happen to believe that these health inequities are just a particular instance of social inequities, and we're not going to get rid of health inequities unless we deal with those social inequities. But that doesn't mean that in a particular given event like this pandemic, that we couldn't do more in that regard.
Well, that is a nice segue to that wonderful communication you sent out in February of 2018, it was, right? I think it was 2018. It was February 2019.
Oh, yeah.
And it was a very controversial communication for many people, apparently. I thought it was brilliant. I thought it was a very strong, courageous, and gutsy statement that came from your life experience and from your mind and your heart. Can you talk about that and also the response? Because in terms of that hit an issue then that manifested itself when we look at in the following February, you were one of the early ones to say, hey, this virus is a serious threat. So if we could go back to that memo and talk about some of the racial issues that you highlighted.
You're referring to I usually write a weekly message to all the VDH employees. We have about, I think on the books we have 3,700, but right now we probably have about 6,000 people working for us with all the contractors and everything for the pandemic. So I write this weekly message. And after the whole blackface incident, I wrote a message which talked about how outraged I was about the incident, that this was a horrific thing for Blacks and others. I explained why blackface was problematic, and then I used that as a way to talk about racism and racial discrimination. I talked about, I used Kamara Jones's definition of racism, talking about perceived racism, racism that's, when you say racism, most people think about the most extreme examples, right? They think of KKK, white supremacists, and so on and so forth. And that is, in fact, one aspect of it. But then there's racism that is personally committed unconsciously, and I talked about implicit or unconscious racial bias, and I also talked about the what I would call internally mediated racism. African Americans and Latinos live in this society and don't go unscathed, and there's some aspects of those racist ideologies that we take on ourselves. And then I said that we as an agency had done a fairly good job of talking about the importance of looking at issues of equity in our programmatic work. So in the work that we do in public health or in fighting chronic disease and many other things that we do. And we needed to continue to do that and expand that. But I also felt it was imperative that we turn that same equity lens on ourselves and look at our agency and look at improving the diversity of the agency, ensuring equity within the agency, and ensuring inclusion within the agency, and that had to be more than just talk and education and workshops those are all important, but we needed to hardwire it in and take a look at all of our policies and our procedures and look at each one saying to ourselves, who benefits from this? Does this advance diversity, equity, and inclusion? If it doesn't, how do we change this policy? How do we change this procedure to make that happen? So yeah, some people were upset, but that was a minority voice. And I think one of the important things that has happened here in Virginia after that event is that the governor and his office took the approach of their response to this was to double down on a whole host of equity issues. And I mean, just Virginia has been amazing in what it has been done over the last year in that regard in terms of legislation, the hiring of Dr. Underwood and the establishment of a cabinet level position on equity. We have a equity plan in place now, One Virginia. All the agencies have been instructed through this plan to establish office for diversity, equity, and inclusion. As I said, the work of our VEST has been infused with this idea. So I can sit down with the governor and the secretary, my immediate boss, the Secretary of Health and Human Resources, and we have a real serious discussion about, okay, how can we improve the equitable vaccination of the population in the Commonwealth, and I have support from that office to do that. So things have gotten a lot better.
Yeah, it took an incident certainly and allowed it to be open the conversation, a long overdue conversation that was happening in back rooms and away from people is now brought into the mainstream and well needs to be happening. I've got a couple more minutes with you, and please encourage other people to put in questions into the chat box, into the Q&A. Your journey from med school, where you also picked up a master's in medical anthropology, correct? While you're at it. So you're editing medical journals in your 30s for Harcourt Brace Jovanovich, and then entered medical school at age 40, and then went to a fishing village. What does this tell us about in rural Alaska? What does this tell us about your values, what matters to you as a physician, a healer, as a teacher, and now as a public servant, leading us during one of the most difficult times where everybody's going to notice what's not going right, and that people are not going to pay much attention to what is actually working well? What does this say about you as a human being?
Well, I've been motivated all my adult life by a concern for the most oppressed peoples around the world and here in the United States. I'm a child of the 60s. I was involved in civil rights movement. I was active in the anti-Vietnam War movement. When I was a journalist, a lot of I wrote hard news, and a lot of what I wrote about was struggles, the labor workers and labor struggles, or I was down in Grenada covering the Grenada Revolution, and then later the fall of the Grenadian government. I was in Nicaragua when the Sandinistas took power. So I was really focused on these sorts of things, and the more I wrote about that, the more I became interested in what were the root causes of those inequities that I was writing about, and or about the issues that I was writing about. And I was really leaning towards becoming an anthropologist or a psychologist, Jim. I debated that as well. And as you noted, I wound up with Harcourt Brace Jovanovich, which had all the editorial offices in Cleveland. And I was an editor of a group of medical magazines. And then I decided that I could combine those interests. I don't know if this is still the case, but back then, the hottest field in anthropology was medical anthropology, sort of taking a look at how culture and social factors impact disease and illness, or taking an anthropological look at the medical profession itself, right? And Case Western was a real leader in that. So I decided I wanted to do that work, and I managed. My wife was a tremendous support. I wouldn't have made it otherwise. Just as an aside, you know how at the Academy Awards and everything, everybody always says, first of all, I want to thank my lovely wife, blah, blah, blah. It's actually true. You never do anything really, really meaningful and outstanding without the support of others. And so anyway, my wife was key to my success in getting into both med school and grad school at the same time, because my plan was to do an MD, PhD in medical anthropology. I have to say, I am one of the 75% of those out there with whose degree is ABD. So, but I figured one doctorate was enough. What does it say about me as a person? I think even though it looks like I've had a jagged path, journalist, medicine, clinical medicine in Alaska, academic medicine and research at UVA, then public health. There's a connecting thread through it all, which is a concern for the health and well-being of, in particular, people of color, and trying to figure out a way to both explain it and then, importantly, do something about it. I went from feeling like I wanted to take care of the person sitting in front of me in the clinic exam room to wanting to take care not just of the diabetic patient sitting in front of me, but all the diabetic patients in the practice, or all of the diabetic patients in the UVA's patient panel. All the covered lives, so to speak, that UVA dealt with. And then finally, I just said, you know what? I'm actually concerned about the whole population. So I jumped and I went to public health, and so I feel very good about what I'm doing.
I love that span of career. We're just going to turn now to the questions that are coming through, and maybe as a public health physician too, you can allay some of the anxieties and concerns, because I remember watching you do this in a meeting we had a few weeks ago so well. When you look at, and you addressed this earlier with the B117 variant, what can we tell people when there's that discussion about we've got 94, 95 with Moderna and Pfizer, but only 65, 66 with J&J, am I getting the lesser vaccine? Can you just, in just a couple of minutes, let people know what it is in terms of, what we're looking at, the success rate, and what that really means from a practical standpoint? Because I think we've got this illusion vaccines are 100%. And so if we've got a bunch of other questions too.
Right. Well, the Johnson & Johnson, we need to change the narrative on Johnson & Johnson vaccine. It came out, and the narrative was it's less effective than the Pfizer and Moderna vaccines. The Johnson & Johnson vaccine is 100% effective in preventing hospitalization, serious illness, and death from COVID-19. That's huge. It's as effective as the Pfizer and Moderna vaccines on that. It's less effective from preventing mild disease. there's hundreds of coronaviruses. It's one of the viruses that gives you a common cold. And so, you know, if the choice is, you know, I'm going to risk getting something like a bad cold from having this vaccine, versus preventing death, I think you can see it's worth doing. I definitely would. I would encourage everyone. The best vaccine to get is the one that gets into your arm of the three that we have.
That is great. And I love how clearly you state that. It was when you made that statement during our meeting, I was like, oh, that makes perfect sense. And that logic is helpful. We do have a question about the relationship between public health and public safety, that mistrust in public safety is high among many populations. And how does this then contaminate potentially public health and the vaccine distribution? And can enhancing trust in public health enhance trust in public safety and policing? So this is from our own Dr. Will Pelfrey, just asking about the relationship between the two. Just very, very interesting. I'm scratching my head. I'm thinking like, I know there's some deep thing here, but any thoughts from your side on this?
That's a very interesting question. So I work with a lot of public safety folks. The EOC is run by, when we're not in the middle of a disaster, it's run by the Virginia Department of Emergency Management, which is in the Department of Homeland Security and Public Safety. I think that police violence is I would call it a public health threat, particularly for Black and Brown communities. And the mistrust and fear of police forces is grounded in a very long history of trauma from that source. So to me, it's completely understandable. We have not utilized a lot of public safety folks in the actual administering of the vaccine. When we do a large vaccination site, there are public safety issues that have to be dealt with, traffic control, things like that, and we do have them involved in that work. I think the National Guard, for example, has been heavily involved with us in doing testing, and we now have I'd say about 200 of them, about 10 teams who are prepared to help out on vaccination, so they can augment some of the work that we're doing. But primarily, we're doing this with civilian forces, and I think that's appropriate.
And very intentional, it sounds like.
And intentional.
Yes. Mm-hmm. There's some questions in here, and we have a mutual colleague, of course, who is battling cancer and just got her first vaccine the other day and was very happy about that, which is wonderful. But we are seeing a little bit of that vaccine envy that people have been discussing. You know, people are wanting to know, well, who's getting it first and who's not. And there's still a lot of people, when we're talking about looking at a population of what, 8.5 million or so, we're looking at, there's going to be some fluctuations and variations in terms of who gets in front line first. But every day, I think people are concerned, could this be the day somebody gets, instead of the vaccine, they get the virus? Yes. Any thoughts on how to encourage people to manage the system? Because I was one of the folks that managed the system. It seemed to work very well. Got an appointment coming up and very happy for that. You know, if I had a ticket, I'd want to give that ticket to somebody else who might need it more than me. So any advice on how to take care of our loved ones?
Well, as I said, one of the issues we had initially was the scarcity of the vaccine. I would say that's not the problem anymore. We're going to go through the next phases of this vaccine relatively rapidly, at least here in Virginia. We focused initially on phase one, and with phase one, we had a group of essential workers that we wanted to do, and we wanted to do a group of people who were particularly vulnerable to COVID-19. Phase 1A, that was healthcare professionals and residents of long-term care facilities. Phase 1B, the essential workers, there was a list of 10 or so different categories. That was the workers we were going to do. And the vulnerable population was people over 65 years of age or any adult 16 to or older who had any kind of underlying medical condition which would put them at increased risk. Those two populations together are about 5 million people. We have to vaccinate about 6 million people, right? Because we're not vaccinating children, so you got to take children out of that 8.5 million. We are going to probably saturate that phase 1B population, I would say by mid-April, at the speed that we're going now with the increased number of doses. And what's left of 1C is just a group of other essential workers, and that's a relatively small number, 500,000 or so, that we will go through in a couple weeks at most. So ironically, or maybe it's not ironic, but everyone got really nervous when President Biden said that he wanted all adults to be eligible by May 1st. I actually think we're going to hit that in Virginia. And we'll open it. Probably, this hasn't been discussed, so maybe I'll get slapped on my hand, but I suspect that we'll be opening it up to the general public sometime in May. So anyway, I say that all of that is deep background so that I could say to you that the advice to give to loved ones is that we're going to get vaccinated soon. And by soon, it's a matter of weeks at most that everyone will be have that opportunity. I would encourage people, as we set up these large throughput community vaccination sites around the state, that's one way to do it. The amount of vaccine that's going to pharmacies has greatly increased. This past week, those pharmacies got a couple 100,000 doses, and that's independent of the doses that we get. So that it comes directly from the federal government to the pharmacies. We've added more and more pharmacies to those programs. Wegmans and Harris Teeter were added this past week. So there's a lot of ways to get it, and as we move to the general public, we'll also be shifting supplies so that community-based practices and providers will be able to get vaccine. So you got that outlet, you have community health centers, you got these mass vaccination sites that we're putting up. The health department is doing community-based sites, and you have the pharmacies. So there's more channels, there's more vaccine. Know that you will be able to get vaccinated soon. I know it's been a long wait for some people who may have signed up back in January, but your turn is coming.
We do in our engagement with folks always tell people, take time. It's better that you live to see the summer and just keep practicing those precautions and slow down the vacations. That's what we're about. We have a question about the children, teens and kids. What is the approach? What's the long-term medical view about vaccinating teens and children?
There's ongoing trials right now. There's a trial for, I think it's Moderna, that is looking at children aged 5 through 16. Um, and I think the way that trial is going, they could have some good phase 3 evidence by this fall. And there's another trial that's looking at even younger children. But my guess would be that the earliest we would see children getting vaccinated would be this fall, and probably even more likely in the spring of next year.
Great, thank you. And we do have a specific question, but somebody is asking about any anaphylactic reaction to the vaccine. Any words on that?
There's been about 20 known deaths across the US. So, we're talking tens and tens of millions of doses of vaccine and 20 deaths. So it's an exceedingly rare event. There are more cases of actual anaphylaxis, but as people may know, standard protocol for any vaccination site is to have epinephrine on site, and people trained to use epinephrine which can immediately stop an anaphylactic reaction. So that's the reason why when you get your vaccine, you're asked to wait for 15 minutes, because that's 15 minutes is about the time someone's going to have an anaphylactic reaction. It usually happens within that time frame. So it's in Virginia, we've had no known deaths as a result of the vaccine. There's no known anaphylactic deaths from the vaccine.
Thanks. And I know we're getting some good free medical advice here for some folks. I would like to go back to something that you mentioned about in terms of the policies. And certainly within the Wilder School, policies are so important, and how we might be involved in shaping those policies currently and certainly in the future. One of the things I remember when going through the policy manual and we were providing some feedback on some of the policies is the disparity of dignity and respect in the health community. And for those of us who've done our share in the public health community, whether it be medical or psychological, you're expected to reveal much more about yourself in a very public fashion than you would be if you were going to some West End clinic. And that was one of the things that we cited in there in terms of just simple little procedural things that we can sometimes just be not noticed. I just think it's okay. And I remember when reading through some of these policies, I was thinking, where's the dignity of this individual, and why is dignity a socioeconomic status advantage, and why shouldn't that be consistent across the board? Any thoughts about dignity and health?
Oh, that's a big topic.
Yes, yeah, just a small little question.
Yeah, just a real simple, easy question there. Yeah, people of color are not. What's the best way of saying this? In addition, part of the essence of racial bias, and again, I'm not talking about out and out explicit racism and white supremacy, but any aspect of racial bias, including unconscious bias. Part of seeing another person as being lower than you includes a sense of them being less than human, right? I mean, since you are the human, and if they're less than you, they're not human, and it gets reflected in all kinds of ways, right? So I had a colleague in psychology, in social psychology at UVA, Sophie Treywalter, is a professor there, and she did all these studies around pain, and showed that slamming your hand in a car door, right? People would rate blacks as not feeling that as much pain from that as a white person. And she did this in all kinds of settings, among her students. She did it with nursing students. She did it with a bunch of people. And then she and I did a study looking at this among physicians, well, among medical students rather. It got published. We did this study without any funding, and we wrote it up, and it got published in the Proceedings in the National Academy of Science. It was a huge uproar. People may remember this. We took a bunch of just stereotypic ideas about blacks. Our skin is thicker. We have fewer pain receptors. I mean, we came up with a bunch of things like that, and turned out that these sorts of ideas about the differences in biology between whites and blacks were held even among medical students and residents. Anyway, I believe that those sorts of things are the things that lead medical professionals, clinicians, psychologists, and all those who are supposed to be taking care of us to in their daily practice treat people of color with less dignity and respect than they treat others. So, and it's done, and this is where that term microaggressions comes, right? There's all kinds of ways in which any black person can tell you about it. Walking across the street and hearing car doors, the door locks click as I cross the street. I mean, I can't tell you how many times that happens. It's rampant, and I think we're going to have to really change our culture around that.
I think so. No small thing to close on is the need to change our culture. And you've given us so much to think about today, Dr. Oliver, as always. And being with you is a unique pleasure. We enjoy working with you. We tremendously respect your values, your life history, your story. We will have to continue the conversation in Charlottesville over wine, and anybody can join us when we can go live again. But we just are so grateful for your time, and especially when there's so much demand for that time. We appreciate your leadership so much.
I really appreciate the Wilder School. As I said, we've benefited from the work of your leadership, and it's helped out with our response to the pandemic. So we're in this together, and together we're going to get this pandemic behind us.
Thank you so much, sir. We appreciate it.
I'd also like to thank Dr. Oliver, Dr. Burke, Dean Gooden for this incredible session and discussion. And also a wonderful thank you to each of our participants for today's session. We hope you will complete the survey evaluation about the session that you just saw or participated in. And this includes suggestions for future topics for upcoming Wilder School Lunch and Learn sessions. A recording of this session will be made available on the Wilder School YouTube site or channel. And we will share this via email with all of our participants, as well as all of our registrants for the session. We will announce our next Lunch and Learn session for May when additional details are available as well. we would like to encourage you that in April, we absolutely welcome you to join us for our Excellence in Virginia Government Awards Recognition Program, which will be held on April the 15th at noon. This event is open to our community, and you will see a link at this time in the chat. I will also be sharing this link with you in a follow-up communication. This program celebrates the significant contributions and successes of individuals and organizations in the public and private sectors that have created positive impact and elevated our citizens and government communities across the Commonwealth of Virginia. As you can see here from this amazing honorees, as well as those distinguished individuals and organizations that we have recognized in previous Excellent Virginia Government Award programs. Thank you again for joining us for today's session. We truly appreciate it, and we hope to see you all very soon. Thank you so much from the L. Douglas Wilder School of Government and Public Affairs.